Welcome to the LMD Podiatry Podcast. Trust us to get back on your feet. Here's your host, Dr. Lauren Dabakaroff.
Hey everyone, Dr. Lauren Dabakaroff here with the LMD Podiatry Podcast. We have a special guest today, Dr. Wadehra. He is a colleague of mine, and we do a lot of the same stuff. And we're gonna kind of run through all that. How you doing, Doc?
Good. Thanks for having me on this. This is great.
All right. So tell us about yourself a little bit so everybody knows who you are, where you're from.
Yeah. I practice in the suburbs of Detroit, Michigan. I'm in a city called Birmingham, Michigan. Started a kind of like a hybrid concierge practice a couple years ago. Really specializing in minimally invasive foot surgery, but also regenerative medicine, which I know you and I are going to talk about quite a bit here shortly.
Very exciting. So why don't we just I like to always open with what is regenerative medicine and why is it different than the conservative approach that everybody's been used to for the past many decades.
Mm-hmm.
So basically, regenerative medicine is, I like to call it like harnessing the body's ability to heal itself. Like a lot of things become chronic, like plantar fasciitis becomes chronic sometimes, Achilles tendonitis. People have chronic sprains and things like that. And then there is not much in the world of traditional medicine that gets those areas to heal. And that's when regenerative medicine comes in. We use things that have special qualities and properties that kind of wakes up those cells on a cellular level to heal. What do you use in your office, Dr. Wadehra?
Yeah, I think you put it really well. I like the the way you describe regenerative medicine. That's how I talk to my patients about it too. The body is very smart. If you give the body what it needs, it truly can heal itself. But to answer your question, we utilize a variety of different methodologies. One is shockwave therapy or EPAT therapy. We do a lot of laser therapy in the office too. But my favorite really is utilizing different biological injections, not steroid, but biological injections.
Right. Because steroid, it won't actually heal the area. So let's say you take the plantar fascia. It's a very tight band on the bottom of your foot, and fascia doesn't stretch. And then what the steroid does, it actually just removes some of the inflammation, and it doesn't actually heal that structure at all. In some cases, it can help. Like it'll take away a lot of that inflammation, allowing kind of like for the environment, a good environment for the foot to heal, but it doesn't actually repair anything. And then when it comes to other things, or if you inject the steroid around tendon, it can be very harmful. It could actually weaken the tendon, weaken the ligament, and cause other damage, and puts you at high risk for tears and ruptures down the line. So that's what we kind of want to avoid. But unfortunately, traditional medicine goes there a lot of times. So I think you and I use the same biologic. Use the DPMX injection.
Yeah, I use a variety of different injections now. I do utilize them from time to time, but I've been kind of dabbling with different types of Wharton's jelly products, along with exosomes and actually products that even contain live cells. But yeah, again, to answer your question, DPMX is definitely one of those that I use quite often.
Well, what are the other ones that you use? Because
I've been utilizing
basically like a Wharton's jelly, and the way I explain it to patients, I just say it's the thickest part of the umbilical cord that's the most rich in native or stem cells, and that they have all these properties that are pro-inflammatory, and they basically tell the body to heal itself on a cellular level.
Yeah, no, that's exactly the way to the way that I describe it to patients as well. It's almost like, I'll use the analogy sometimes, and I'll come back to cortisone for just a second. Cortisone, like you described it, is like a Band-Aid approach. It turns the pain off for a little bit, but we haven't done anything to actually heal the issue at hand, the root cause. So what I'll tell patients is, when you inject something like Wharton's jelly, it has all the ingredients that we need to truly repair the problem at hand. So an analogy I'll use sometimes is, imagine you have a hole in the drywall. You're going to go to Home Depot or Lowe's, you're going to buy a drywall patch kit that has all the ingredients it needs to fill that hole. That's exactly what Wharton's jelly is giving the body the ingredients it needs to patch the hole, patch the fracture, whatever it is, truly giving the ingredients it needs versus just putting a Band-Aid on it and then hoping something happens. But as you know, most often when you do that to patients, they come right back through the door saying, "Doc, it worked for a little bit, but now I'm even in more pain."
Yeah, I see that all the time. So I personally like to use the Wharton's jelly in conjunction with laser.
Mm-hmm.
And I actually have higher success rates with it because most patients don't listen. Like, not in a bad way, but like I had this guy, I gave him the Wharton's jelly injection. He felt, for his fascia, he felt so good. He started like climbing the canyon, the Grand Canyon. I don't know what he was hiking over there. And then he like uses ladders at work. And I'm like, and then I actually do a lot of diagnostic imaging in my office, and I have an ultrasound, and I took a look at his ultrasound to see why he was in so much pain. It was amazing. In 3 weeks, the fascia actually shrunk in size. The normal width of the fascia is about, his was bad. His was like 7 millimeters or more, and then it was already down to like 5.5 millimeters, which is amazing. But you saw all this inflammation around it. It's like, great, I gave you this medicine to get your body to heal itself, and it's doing a good job, but you're aggravating it. So once I like forced him to kind of go in a boot, and I had him do 6 I used the MLS laser. We did 6 sessions at the MLS. I never saw him again. He was fixed. He gave me a testimonial and everything. And ever since that, I don't let patients get the injection without it, because I love the MLS laser. It tells your cells the mitochondria in your cells to make more energy, and it takes away a lot of the inflammation. And I actually have found a lot of studies that it actually enhances the ability of the Wharton's jelly injection and all those type of biologic injections to work better. So do you use that in conjunction, or you do it separately?
No, I very routinely will package it with Wharton's jelly with a combination of MLS laser and shockwave therapy. I find the two, especially with heel pain, I find that the MLS plus shockwave actually complement each other very well. And then you throw the injection on top of it, you create a really nice sound environment for some really good healing.
So in what cases do you do the shockwave for, or you just use all 3 modalities for?
It really primarily my soft tissue type of tendinopathies, so Achilles tendinosis or plantar fasciitis will utilize the combination of the two. Very rarely am I doing just shockwave alone or just laser alone. Of course, neuropathy patients, those are probably just going to get laser alone. Or post-surgical patients, we do lots of MLS. But again, for these chronic conditions that patients are dealing with, again, soft tissue wise, I like the combination of the two, the shockwave plus the MLS laser.
Well, what is I know you use the EPAT, right?
Yeah,
I don't have that machine. Okay. So how is it different than the extra corporeal shockwave?
It's under the same family. Essentially, there's no electromagnetic type of methodology behind it. It's basically high pressure sound waves that are being pushed into the patient without the use of any sort of electromagnetic, again, type of product. But the idea is the same. The idea is that we're stimulating, I call it exogenous inflammation, if you will. You're creating inflammation on purpose to jumpstart the body with the shockwave or EPAT therapy. And so we're bringing good blood flow to the area. We're breaking up scar tissue. We're bringing the body's own natural stem cells to the area. I find that if you pair it with MLS similar, it'll bring good blood flow to the area, but it'll then flush out all the bad cells, the histamine releases that we get, the bad, you mentioned mitochondria, right? We basically recycle the bad mitochondria, bring fresh mitochondria to the area, and the mitochondria releases ATP. So I found that the two together really create a really great environment. And then you hit them with some Wharton's jelly on top of all that.
So how do you separate them? You do the EPAT, you do the shockwave first, and then MLS, and then like how long do you like separate it between the like?
So it's a good question. I've been playing around with different type of protocols and talking to colleagues, but what I found that works really good in my hands, if you were to just, if you do like utilize these three types of modalities, let's just use plantar fasciitis or fasciosis for a second. I typically will start them with I'll start with EPAT first, and that same as soon as we finish the EPAT round, I'll hit them with MLS laser, and I'll do 2 to 3 of those. And then have them on the third visit.
In the same time that they're there?
Same time they're there.
Oh.
Same time they're there. And third visit, we'll have them come back and we'll just do the injection that day. We won't do anything else. I'll wait 2 weeks and then start the process back over again.
So you do the EPAT and the
MLS.
The MLS in the same setting.
Mm-hmm.
And you do what, 3 in a row, each one a week apart?
Yeah, I'll do 2 to 3 first, and then 2 or 3 first, 2 to 3 weeks, and then back in for the injection. Wait 2 weeks, and then give them 3 more rounds of that.
I spoke to Dr. Spear. He's also one of our colleagues. He said that he does the EPAT 3 in a row, and then he does the Wharton's jelly, and then he does another 3 EPATs, and he gets really good response from that.
Yeah. I've heard some people just do 3 rounds of EPAT and then Wharton jelly and call it a day. So we don't really have any, quote unquote, good protocols yet. It's all anecdotal.
Right. I know. Because regenerative medicine, it's a brand new field. The whole point is like we said, just to get the body to heal itself.
Right.
So I'm a stickler for immobilizing the patient. Do you put them in a boot?
Yeah, I do. I recommend it. I mean, do patients listen to me? That's the other, that's the other half. Who knows?
They don't listen to me.
Right. So you just, I tell them this. I said, look, the boot is to do 2 things. It's number 1, to give that foot just a break from life so that we can truly allow it to just start healing. But it allows you to stay mobile. The second reason I like the boot is because, it keeps that injection pretty much where I want it to be versus spreading out. Now the foot's small structure, so would it actually spread out and they'll lose the area? I don't really think so, but I like the boot because it truly just gives them. It reminds them that they had something done recently too, so they should just take it easy. But again, like your patients, my patients sometimes don't listen to me. They want to get back to life. You can only educate, right?
Yeah. I mean, I think I always make the analogy. I tell patients all right, this is the problem with your foot. And then I tell them, if you sprained your wrist or dislocated your shoulder or something, you'd stop using it for a couple of weeks and you feel better. And then the problem with, us, our field, foot and ankle specialists, nobody stops using their foot. And then I just keep kind of reinforcing, how do you expect your body to heal itself if you keep using your foot all the time? Your foot, the pain is a signal. It's a blessing from your body. It's your body telling you, please stop using me. So you have to listen to your body. You can't just walk this off. And then, with the regenerative medicine, healing time is pretty much half of what most people expect. I do it a lot for sports medicine injuries. And I've had a really good, some people that have a really bad ankle sprain, whether it's the ATFL or the deltoid, I confirm it with the MRI and give them the injection, put them in a boot. And then I actually you could actually on the ultrasound see only 3 weeks later that everything is filling in. Whereas traditional immobilization for ankle sprains, maybe in 6 weeks it'll close. So
that's pretty cool. That's cool that you can see that on ultrasound. I agree with you on that acute injuries, it works really, really well. Are you utilizing Wharton jelly for post-surgical patients?
That I'm not there yet, because it's funny. Down here in Florida, patients don't want surgery. They don't want time off. They don't want a boot. They would rather live with their pain, or I don't know. It's just, I mean, I know you do minimally invasive surgery in your office. I do the surgeries that I do are mostly like I do some like bunions and hammer toes and things like that at the surgery center. But yeah, I have been. The only thing I encourage post-op is the MLS laser because it does help the incision heal a lot better, and a lot of patients have a lot less pain after the surgery and they heal a lot faster. But
If you started to add, yeah, I add a lot. I do a lot of Wharton's jelly post surgery for my patients. So after I put my last stitch, instead of hitting them with the common cocktail we all used in residency, or other practices, little lidocaine or with some Dex at the end, I just do Wharton's jelly at the end, and I have found that. I mean, the patients that sign up for that versus don't, it's a night and day difference because, even with minimally invasive surgery, you're still dealing with pain and swelling. That never goes away regardless, but it really does decrease the edema I see with patients. Also, just overall pain-wise, pain is substantially decreased. I'm seeing unionization on x-rays faster with these patients too. And then of course I use MLS all the time for post-surgical patients. So again, it really creates the two really create a great environment for patients to heal fast. I think MLS alone is phenomenal. I love MLS laser. It's a great modality.
I love it. My patients are so happy. It's like, especially the neuropathy patients, it's like a gift because there's like this new technology. The technology has been around for a while. Like I remember, laser from when I was in podiatry school. They had them show us how to use that laser and what it does.
Yeah. I wish they would show it more. Back then we were all skeptics. But we're now in the field practicing.
Talking badly about low-level laser therapy, and then the MLS is different because it's like it's a double beam. It's a double laser beam, so it's a healing laser as opposed to the other lasers out there.
Yeah, it's definitely the premier laser. And here's another thing. I tell patients because sometimes they're skeptical, and I go, this company, Cutting Edge, and we're not sponsored by Cutting Edge, by the way, just FYI. If your patients are seeing this, I want them to know we're not getting paid to say this. I'm just saying this because I truly believe in the laser. But if Cutting Edge wants to pay us, I'm sure we're here for that too. Anyways, the company was actually designed for veterinarians. I don't know if you know that. For 6 years.
I heard about that. Yeah, I heard about that.
You cannot fool an animal. There's no such thing as placebo in animals. If your dog had just had ACL surgery or something, a fracture, etc., that ORIF, open reduction internal fixation, or they just are having bad arthritis because animals do. This laser really helped a lot of these animals. Now, finally, 6 years later, they bring it to human medicine. You can't trick an animal, and my patients who go through it also just swear by it too.
Well, when do you not use the Wharton's jelly injection?
Honestly, I try to use it for everything. I don't use cortisone in my office. If I have a patient that is asking me for cortisone, I actually will just refer them out because I don't believe in cortisone. I truly don't. No, I don't. I don't believe in it. I can count on one hand how many times I've used it since I started my practice here. But ortho group, I use it all the time. But I saw a lot of bad reactions with it, so I refer people out.
So I still use it mostly because I don't have the hybrid concierge model that you have yet. I see a lot of insurances and people want what is covered by insurance, and that's what's covered. I tell them, Wharton's jelly fixes your issue. The only thing that's covered by insurance is talking to me, a prescription for medication, physical therapy, and a steroid injection.
Well, it may be. We don't even know nowadays with insurance. They're cutting everything now. Sometimes even physical therapy is not covered by insurance anymore. It's actually kind of ridiculous what's happening.
They limit it like per year.
It's
it's sad, but that's. I tell patients it's kind of sad that like medicine is advanced and there's actually evidence-based medicine to support all the things that we are doing, especially. The Wharton's jelly injections. I've seen a lot of studies on it, but these Medicare guidelines are not keeping up They're like stuck.
Oh, they're so backwards. Don't ever
Yeah.
expect regenerative medicine to ever be covered by insurance. It's never going to be. It's you and I can have a whole different talk with you about insurance, but I'm not a fan of. I hate health insurance. I have health insurance, but health insurance in our country nowadays, truly by 2030, the average deductible will be $10,000. That's what we found out. So your health insurance is truly for catastrophic reasons at this point. God forbid you're in a life-threatening accident. You need to go to the hospital. You have a life-threatening illness. You have a baby. Those are reasons to have it. But to come see you and myself, your health insurance really is not going to be applicable. You're going to be paying a high deductible. A deductible to see us anyways. So why not use that money and use it towards something that's actually going to help your health versus something that's going to put a Band-Aid on it versus something that's going to keep you coming through my door over and over again. You're going to get frustrated with me. Doc, you keep giving me the same injection over and over again. Why am I not healing? Mrs. Jones, remember what I told you. Steroid is only a Band-Aid. It's not something that's truly going to help you.
I actually there's an example I use on myself. It's like a sad example. I don't like to talk about my personal life too much, but like I need a fertility doctor to help make babies, right?
Sure.
And according to Blue Cross Blue Shield, like I have insurance. And according to the insurance guidelines of my insurance company, it's not medically necessary to have children. So they refuse for any fertility treatments. And like that's where society is going. And it's like we're in a birth rate decline. And I hate talking. It's like sad, but like, and you know what? I took out my credit card and I'm paying.
And you paid for it.
And I paid for it. And then sometimes it was successful, and thank God I have a beautiful 3-year-old daughter. And then I had lots of failures before her, and I had a couple after her. But it is what it is, and I paid for it because it's something I want. So like I tell my patients, if you want, you don't expect your insurance to pay for everything. There's like this mentality that they want insurance to pay for absolutely everything. And it's not reality. Like,
it's not reality. So I first of all, thank you for being vulnerable and sharing the story. That's that's not easy to share. But to your point, right? You paid out of pocket for something that you truly believed in, and you have a daughter, right? 3-year-old daughter. That's amazing. That's a blessing. So if you truly believe in something, you're going to do whatever it takes to get it. That's how my personality is. So I think that's the way the message is to our patients too. It's that, look, there's a lot of great modalities that are healthier for you, right? That's the other thing, is we don't talk about side effects. These insurance companies will cover the blood pressure medication, the statin, the whatever, okay, but there's no talk about the side effects, the illnesses that come and follow this medication. Just because it's covered by insurance, let me take it. Right, but let me now educate you on all the bad things that can come with it, and you let me know if you still want this medication.
Yeah, I tell patients with neuropathy, like I tell my patients, all those like gabapentins and Lyricas that they use, I say, it doesn't fix your neuropathy. We have to do things to wake up your nerves, right? Because that's the whole point of regenerating the nerves, regenerative medicine. So for neuropathy, I do a combination of vitamins, CBD cream, and the laser. Patients feel better by like the 3rd or 4th session.
Yeah, that's phenomenal.
I don't give them any medications, and I encourage patients to exercise more. It really helps stimulate the nerve to wake up. But all those other pills, they just put Band-Aids on it, and they have really bad side effects. Even today, why did they put me on an antidepressant for my neuropathy?
Yeah, they do that. No, they do that. That's actually a very common practice nowadays. Again, these docs, and I respect all our colleagues, okay, but
yeah, so do I. But we're people like you and me. We're in this for, I guess, we're out of box thinkers. And that's why I started the whole regenerative medicine game, because I really I like to fix the root of the issue.
The root cause.
Even with fasciitis, if their calves are extremely tight, I actually use my shockwave machine to loosen up their calves and break up all the adhesions in the abdomen.
You told me that. That's pretty cool.
Works pretty well. And physical therapists use it, and why not use it in a combination? And chiropractors use it too. Why shouldn't that's why I started using it as part of my protocol, because if they're tight and they did physical therapy or they're too lazy to stretch at home, 1 or 2 sessions of the shockwave just on the leg, the back of the leg, loosens everything up and it takes so much pressure off the fascia. So that's why, like, every patient, case by case, like I have to see like what's causing the tendonitis, what's causing the fasciitis.
So if a patient that comes in with plantar fasciitis, are you doing the calf or the aponeurosis first and then and then the heel at the same time?
Yes, I am doing it at the same time. Like if it's like, I was just thinking, so I had someone on Friday, we just did the legs because she just had the tendonitis, the Achilles tendonitis. But for fasciitis, I do both the calf and the fascia.
Okay.
When I do the shockwave, the patient, most people sign up for shockwave because there's no downtime versus getting the Wharton's jelly injection.
Yeah.
So that's like, they actually feel better right away. The shockwave, it breaks up all that, so the adhesions, brings new inflammation to the area. I also tell patients not to take anti-inflammatories. I tell them, you want the inflammation. It's good for you. It'll help heal. But and every time I tell patients that with the Wharton's jelly injection, they need the boot, they kind of, they deviate from that.
I know what you mean. There's something, I don't know what it is. There's something about wearing a cam walker for 2 weeks. It's just life. It's almost like their life is over. I don't understand that.
Especially the driving foot, it kills them. People don't want to be limited. I get
it's inconvenient. It's inconvenient, but then you got to paint that picture, right? It's like, look, it's 2 weeks of your life versus 2 weeks of your life is a drop in the bucket compared to how long we live as human beings. So 2 weeks to truly try and get you out of pain, I think, is something you can do for yourself.
I actually have a patient. Have you ever seen these like peg leg walkers?
Yeah, I've seen them.
It's like you put your knee in and like you have a peg leg, and then your foot's hanging up in the air.
I've seen that.
She's like, I get a lot of looks at the store, but it works. She finally like kept off her foot, and her fasciitis went away. She's so happy.
That's great.
Yeah. Any other nuances before we sign off?
I was actually going to ask you, what's your neuropathy protocol for MLS?
Okay, so I do 12 sessions of MLS to start with. For first 3 sessions in the first week to create the buildup effect in the cells, because you have to wake them up. And then I do the EBN6 vitamin from the EBM company. It's a great vitamin. It helps glycosylation and renewal of the nerves. And then I encourage patients. I also set up the physical therapy, especially the older population, physical therapy to just do like gait training and balancing, just to try to get them more mobile. Yeah. And then the other thing is, I really like the CBD cream. And if the patient doesn't want to pay for it, then they go get some over-the-counter capsaicin cream that works as well.
I see. No, that's very similar to what we do too.
There's also a machine that sometimes I prescribe if the patients have insurance. It's called the Zynex machine, and it has it's like a TENS unit, but it has an interferential current on it, and it stimulates the nerves to wake up and heal, and it helps a lot with the symptoms of neuropathy as well.
Oh, that's interesting. So you do 3 sessions of MLS the first week, and then you do 1 session per week after that?
No, 2.
2 per week? Okay.
I do 2. Yeah, so I tell patients the more they do it closer together, the faster the nerves wake up. I actually had one neuropathy patient that did 5 in a row and felt like $1 million.
Awesome. And are you doing their protocol where you let the robot go over the dorsum of the foot and then you use the trigger point laser to hit the legs? Is that your protocol?
No, I do each leg. I do the right leg from the common fibular nerve all the way to the dorsum of the foot. And then so I do 9 minutes on each leg like that. and then I put the bottom of their feet together, and then I do another 9 minutes with the bottom of the feet together.
Okay.
So
and you're letting it's a robot?
Yeah, it's the robot. Like it's a free. I didn't hear you. What?
It's you. I think you introduced. You said M7. You got the M7, the robotic.
Yeah, I have the robotic one. So it has the handheld piece, and it also has. So we just do the setting. We do the whole entire leg, both legs. It runs for 9 minutes. We scan it, and we run each leg for 9 minutes, and then the bottom of the feet together, another 9 minutes. So the patients are here for about half an hour, but it really does work. And I always crank it up. I always double power it because I want to do right by my patients and get them the most relief. And my patients, I also do that for chronic arthritis. I have someone, I actually treat knees down here sometimes. I have like a mailman with bone-on-bone knees, and he really doesn't have time to have a knee replacement. And he just comes in, gets a couple, he did the initial like 6 in a row, and then he comes in about once a week for maintenance, and he feels a lot better. And he doesn't have any pain when he scoots in and out of his mail truck. And he found a way to get his pain under control without surgery, without injections, without pills, and he's very happy.
Great.
So it's like I use it for a lot of things.
That's really nice.
Knees are great. Any arthritic condition, great for it.
That's really nice.
And they end up using less pills, causing side effects. So I'm happy. The laser is amazing. The gel is amazing. And then it's just interesting how all my colleagues use them differently, and how, like, what I do is I just give the injection first, and then I do 10 or 12 MLS in a row with the boot for about 3 weeks. That's my protocol, but it's not. I could see where doing the shockwave and the MLS at the same time works a lot better. I didn't even think of that before. So it's really cool, very interesting.
Yeah. It's just, like I said, there's a million ways to skin a cat, right? So that's the same thing here. Is that there's so many ways to achieve the same the results, if you will.
Yeah. All right. Well, thank you so much for coming on my podcast today. I love collaborating with other colleagues and seeing what they're doing, and we're doing great things together. We're just helping other people, all the patients with pain. And Dr. Wadehra, thank you so much for your time, and for all the people in Michigan. Hopefully they'll get around to hearing us together.
Thanks for having me on. I appreciate it.
Thank you so much. Have a great day. See you next time.
You too. See you next time. Bye.
Thank you for listening to the LMD Podiatry Podcast. For more information, visit lmdpodiatry.com. That's lmdpodiatry.com. Or call 954-680-7133.